afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on Public Health 2.0, Black Health, COVID-19, and vaccines. My name is Dr. Carl Cabasel, and I am Physician Lead for Health Promotion, Chronic Disease, and Injury Prevention at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin with today's presentation, I'll mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation, but please use the Q&A pod for any questions you might have during the session. A discussion and question period will follow the presentation. And if at any point during the session you experience any technical issues, please email capacitybuilding, all one word, at oahpp.ca. I would like to state that as the moderator of this session, I do not have any potential conflicts of interest to declare. So now it is my pleasure to introduce the speakers for today's presentation, Dr. Ronnie, Cheryl Prescott, and Angela Robertson. So Dr. Ronnie is a family doctor and public health specialist. Dr. Norum is the Associate Program Director of the Public Health and Preventive Medicine Residency Program at the Dalla Lana School of Public Health, the Black Health Theme Lead for the Faculty of Medicine, and EDI Lead within the Department of Family and Community Medicine, all of those at the University of Toronto. Dr. Norum is also the host of the podcast, Race, Health, and Happiness, and full disclosure, I work with her on that podcast. And currently, Dr. Norum is the president of the Black Physicians Association of Ontario. Cheryl Prescott is the executive director at the Black Creek Community Health Centre, striving to ensure equitable access to health services for vulnerable populations. A dedicated community leader for over 25 years, she is known as a coalition builder, bringing together diverse stakeholders in community development initiatives that reflect the real needs of the people. Throughout her professional and personal interactions, Cheryl continuously champions equity and inclusion towards the creation of a more just society. And Cheryl is a proud graduate of the University of Ottawa and the University of Toronto, where she earned graduate degrees in science. And also on the panel today, Angela Robertson. Angela Robertson is the Executive Director of Parkdale Queen West Community Health Center and has worked in the government, hospital, supportive housing, and drop-in sectors. Angela has served on several community boards, including the Stephen Lewis Foundation, Black Coalition for AIDS Prevention, and HouseLink Community Homes. Angela is also an activist working with Black, women's, LGBTQ, and low-income communities, and is a founding member of Blockorama that aims to create space for Black communities at Toronto Pride. Angela has published works on homelessness, race, and women's issues, and she is the co-editor of the book Scratching the Surface, Canadian Anti-Racist Feminist Thought, published by the Women's Educational Press. Angela was honored by York University in 2017 with an honorary doctorate of law degree for her social justice work. She has also been recognized for her social change and justice work by the YWCA, Fred Victor Center, Urban Alliance on Race Relations, and Now Magazine. So as you see, we have a very esteemed panel. Welcome to everybody, and I will turn it over to Dr. Norum to begin the presentation.
Thank you so much, Dr. Carl. And so thank you all for joining us. Let me get to the next slide here. There we go. So as far as presenter disclosure, I do have some financial relationships to disclose. So as far as grants and research supports in 2019 and 2020, I was remunerated by PCORI at CAMH to examine treatment-resistant depression in older adults. So that was through the Obamacare that was funded through. Also with regards to Speakers Bureau and honoraria, I am affiliated with the Talent Bureau, but no payments received. And I do provide education in different spaces on anti-Black racism, both for-profit and non-for-profit, but specifically for profit, Bayer and TD Bank. And my co-presenters, Angela and Cheryl, do not have any financial sponsor relationships to declare. This is a statement by Public Health Ontario, so I'm leaving it here for you folks to read, but PHO is not the owner of the content, so please do refer to that also in future recordings of this session. And for the land acknowledgement, I would like to turn it to Sister Angela to read the land acknowledgement, please.
Thank you. This is an important gathering and an important conversation. And we see this as always important to ground the conversations and the work that we do with land acknowledgement, and to have that land acknowledgement be more than perfunctory, which unfortunately acknowledgements have become, but to ensure that land acknowledgements become resonant with the conversations and the change that we seek to make. So it is within that spirit that I frame this land acknowledgement, that we are having this conversation across many parts in Ontario and likely outside of Ontario as well, that we're honoring that we're having this conversation on the land that is Indigenous people's land. Here in this Ontario, where I'm sitting, is the traditional territories of the Huron-Wendat, the Anishinaabe, the Chippewa, the Haudenosaunee Confederacy, and most recently the Mississaugas of the Credit First River First Nations. Ontario is covered by 46 treaties and other agreements, and is home to many First Nations, Inuit and Métis peoples. And these treaties and other agreements include the One Dish with One Spoon, Wampum Belt Covenant, an agreement between the Irika Confederacy and other nations, and us as newcomers, Europeans, other settlers who were invited into this covenant to peacefully care for and share the resources of this Great Lake and this land. We all here, we are treaty peoples. Many of us who came here either as settlers, as immigrants, as newcomers in this generation and or in generations past. And I, in the context of this conversation about Black health, I also specifically acknowledge those of us who came here forcibly, particularly as a result of the transatlantic slave trade, as what I would say as stolen people to a stolen land. It is a privilege for us to be here and to be in solidarity with Indigenous peoples in the continuing struggles against colonization and its lasting impacts. So in the context of the conversation we're about to have, we bring those principles, we bring this acknowledgement, and we bring the force of that into this conversation, always knowing how intertwined histories and experiences of colonization and racism are, because they all come from the same tree. And therefore, the roots that we need to dig deep on means roots that will bring about liberation for us as Black folks, and in solidarity with Indigenous people's right for sovereignty and land. So I thank you and I welcome you to this conversation.
Thank you. This is why she does the land acknowledgement. Just phenomenal. Thank you so much. And so that's really the essence of our gathering today, is thinking about our positionality and thinking about where we are headed, and a specific focus on Black populations is what we'll be talking about. And so the objectives are here, but very briefly, it's really thinking about the provincial proposal for the Black Health Plan. We're going to talk about race-based data. We're going to talk about the impacts of COVID-19, and we're going to talk about how vaccination and other public health and healthcare work can be done in solidarity with Black communities in a way that respects our self-determination, so that we're not just a partner, but we are actually in the, our desire to lead within our community is respected, and we do that with public health and other healthcare leaders. So my role, before we jump into the objectives, is to really give a bit of orientation. And that speaks to a lot of what Angela already alluded to, which is thinking about anti-Black racism in the context of our society. And specifically, I'll be focusing in on medicine and public health. But really, when we're thinking about this pandemic, we have to realize the impact that the legacy of anti-Black racism has had, such that it did put us at greater vulnerability for infection, but also has been the driver of distrust with regards to government, healthcare, and researchers when it came to the issue of the vaccine. And so in this slide, I'm not going to be reading verbatim the definition of anti-Black racism, but it is the root of the issues that we're discussing today. And so what's very important, I think, to highlight is that anti-Black racism really was brought to us from the legacy of colonialism and slavery, again, as Angela said, and the stereotypes that were created about us to justify the cruelty of slavery. Really, stereotypes of us being less intelligent, having a different pain threshold, dangerousness, subservience. All of these are different characteristics, but ultimately the main message that came through that legacy of slavery is that we were subhuman, and so less than human. And so although slavery was abolished in Canada, give or take about 3 generations ago, it is still ingrained. Anti-Black racism is still ingrained in our policies, our practices, and manifested in the behaviors and actions of people and leaders today. And so because it is a pillar of colonialism, because it is a pillar of broader systemic racism, many of us, including myself, grow up knowing that Black lives are undervalued. And, I don't have a statistic or anything fancy to share with you as to how that is known, because as, my Indigenous colleagues talk about, there are other ways of knowing, other ways of having that situational analysis. And so very briefly, I can say that, growing up as a young Black, a teenager, observing what would happen if a young white person was, an innocent young white person was shot and killed perhaps in a drive-by shooting, and the outrage and the media and even legislation changes that would happen, the outpour, and what by contrast would happen when a Black youth who is, going about their business and was shot and killed in a drive-by shooting, and what the lack of media and lack of legislation change would be. And so as a teenager, as a Black teenager growing up in Canada, you can do that math quick, fast, and understand how Black lives are valued in this society. And it hurts. And so we learn as Black people at a young age that Black lives are undervalued. But for many of us, we continue to have hope because our ancestors had hope. It's why we're here. We hope against all odds. And so we do our best to raise our voices, to pursue education, perhaps, which, if you follow the myth of it being the Great Equalizer, or become professionals or leaders or advocates, only to realize that often our voices are also undervalued. And so we do try to speak out, and we do try to bring attention to the issue that public health needs to understand that Black health and anti-Black racism are major issues. We do speak out on the need to address the collection of race-based data so that we can hold leadership and society accountable for the impacts of anti-Black racism. We do speak out about Black experiences in healthcare and about anti-Black racism that patients experience in the healthcare system. We do speak out about solutions and recommend things like decolonization training and anti-racism training for public health and healthcare professionals. And at times it can be frustrating to continue to have that hope. And in particular, I think during this pandemic, it was particularly a time of frustration at the beginning, where there was so much discussion about COVID-19 being the Great Equalizer, whereas by contrast, our Black health leaders, and I put the report here, and in fact, my co-presenters were the two first authors on this report, stating in April 2020 that Black and racialized people were going to be disproportionately impacted by the pandemic. And so where Black voices are not at the tables, are not heard when they're at the tables, we often see time and time again, lives prematurely lost. And that did happen during this pandemic. But again, I mention hope again, because we are here, because we've also seen a light of change and the possibility of change in seeing that the inequities that the pandemic has made very clear to mainstream society. And of course, the great activism that followed the unjust and public murder of George Floyd, and all of the activism around that has increased attention around anti-Black racism. And so we come here with open hearts and minds, hoping for you folks to bring your listening ears with open hearts and minds to hear what we have to say, and even for those who are partnering, with Black communities right now, to listen, to be committed to action, to do better. And so it is with that hope that I have asked Angela and Cheryl to join me, because they have been doing this work in Black communities longer and deeper than I have. And so it is with that spirit of hope that I now hand over the virtual microphone to Sister Angela.
Thank you, Ronnie. And lovely to be in this room with the over 200 participants who are here. And I know that there are many comrades in the room who are also doing this work. So I see the conversation and the sharing that I'm bringing forward, not just mine and or the work of a small number, but I think it's building on the work that many of us have been doing, and many of you in this room as well. As Ani noted, is in this province, we know that Black populations make up anywhere between 4.5% of the population. We know that there are things and sites of inequality that existed pre-pandemic that were structural sites of inequality that created the grounds for why in this pandemic Black populations have experienced differential impact of COVID. And we also know that because of our socioeconomic locations, we know from a public health standpoint that issues of income deprivation and poor health outcomes are intertwined. And because we have higher rates of Black folks who are low income earners and in low income households, is then that we have also seen higher prevalence of a range of chronic illnesses, diabetes, hypertension, to name a few. In knowing that coming into the pandemic, we knew that there would be differential impact, but we also know that there was an absence and that we would not be able to similar to our partners in the South, in the America, be able to speak to the impact of COVID on Black populations, because we wouldn't have the data, the race-based data. And therefore, we sought to do that. So yes, now moving to the next in terms of questions. So the poll question, so this, a small band of group asked the question, are we collecting race-based data? So I'm asking you to respond to this question, which is, has your health unit been collecting both race and sociodemographic data as a component of your COVID-19 vaccine strategy? So I'll give a few minutes and others who are navigating me through this can tell me, do I need to move on to the next, or do we give a few minutes for folks to, a minute or so for folks to respond to the poll? So asking you, please, if you can respond so we can get a sense. Thank you. So, so from the response thus far, we see that of 155, that 41% have indicated yes, 15% no, 24 not knowing, and another 20 based on where you're located, identified as not applicable. So it is hopeful that we have over 40% of folks who have been collecting the race-based data. And it is because of that gap and that why a small group, a Black Health Working Group, was pulled together. And out of that Black Health Work Group was a table that was created to pull together a Black Health Plan. The Black Health Plan table is a table that is comprised of myself as one of the co-chairs, with co-chair from Kwame McKenzie and Anna Greenberg as the three co-chairs. But really the work that we do at this table is really built on the work of a Black Health Plan working group, a coalition of individuals from community, from the Black Health Alliance, from social medicine at UHN, from community partners, from Wellesley as well. This is also built on work that predates this Black Health Plan work group. So there have been two symposia on Black health, experience of Black folks in the healthcare system. And out of that, there are recommendations that this Black Health Plan seeks to build on. The purpose of us coming together to design and pull together a Black Health Plan was really wanting to respond to the immediate gaps that we saw in COVID, and what are the strategies that needed to be lifted up to be responsive and to bring responsive supports to Black communities. We also felt that it was important to have some clear action and strategies that are very much informed, as Annie said, by community leaders, and by work that Black communities have been done for future, that the moment that we're now in called recovery, and the moments to come that we call sustainability. So the Black Health Plan is built with three pillars: equitable response for Black populations in COVID, equitable healthcare system recovery for Black populations, and sustained health equity for Black populations. Next slide. And one of the foundational elements that we felt and we know is important is the collection of race and sociodemographic data. And I won't go through all of the reason here, other than they're quite visible, but I think we identify the collection of race and sociodemographic data as foundational, because we know that if this information and the sites of inequality is not made visible, then oftentimes there isn't a twin strategy to ameliorate the risks and those gaps. We also know that we need to move from having Black experience be anecdotal experience, but to be evidentiary experience, and that this needs to be then grounded in the evidence of data. And I think lastly, we also know and underpinned that there cannot be data without action, that there must be the collection of data twinned with an action strategy for change. And that action strategy for change must be linked with what we call a bit of a governance strategy around how the data is both analyzed, assessed, protected, and shared. And hence the EGAP framework was developed by that small but mighty group of the Black working group, the Black Health Plan working group, and beginning with a letter that we had shared way back when, in the early part of the pandemic, when we had a medical officer of health who identified that we would all be equally affected and impacted by COVID. Hence, there was no need for race-based data collection. And we have seen that that was an error, and that in fact, there is differential impact. And Black populations have been at the adverse end of that differential impact. Next slide. So the Black Health Plan that has been developed is a plan that seeks to look at, as I said, those three pillars, won't repeat them, but more so at the center is really wanting to address and improve Black health by changing both structural and systemic sites of inequality. And by doing so, that we need to engage community leadership, we need to have data collection, and we need to have community processes involved around its use and governance, that funding must be enabled and be made available, that there must be accountability to ensure that there is action, and that we must use policy levers that are available, because we know that the sites of inequality that is structural does not just reside in health, but they also reside in the broader determinants of health. And therefore, we in health must be concerned with those broader determinants of health, policy directives and issues. Next slide, please. So in terms of, I won't again run through the detail of each slide, but other than to give you a highlight. So under the first pillar around pandemic response for Black populations, this Black Health Plan seeks to highlight the need for the collection of race information, race-based data to inform strategy and intervention, that we need to have a good and sound equitable vaccine strategy, and my colleague Cheryl will speak to that. And as I mentioned, that issues of policy and program and funding must be brought to bear around how do we prioritize Black populations in policies, in program, in funding allocation. Because too often, Black populations, when issues arise, is that we get small pockets of seed funding, of project funding that is short-term, and it's not embedded in the fabric of policy and programs, and therefore the sustainability of those efforts are short-lived. Next slide. That in equitable, in pillar 2, equitable health system recovery, is that we must ensure that the recovery strategies that are being developed now have embedded within them strategies that respond to the sites of inequality and enable access and improve health outcomes for Black populations. So we have identified that we need to ensure Black populations are part of and a focus of all of the recovery strategies. And we have cited some examples of the ways in which that could happen when we look at bringing to bear a focus on mental health, bringing to bear a focus on chronic disease management, bringing to bear a focus on the example of cancer screening when we talk about preventive health. We can move to the next slide. And then when we look at pillar 3, we talk about the fact that we will move through this pandemic. And as we move through this pandemic, we need to ensure that all of the learnings that we have seen to date and all of the work that we do in the recovery work, in embedding equity strategies that we have pushed for and we will push for and ensure that they're embedded in the recovery strategy, that those transformation work must be sustained moving forward if we are truly to have the transformative healthcare system that we say we need and want coming out of this pandemic. And that key to the sustainability is the engagement and the meaningful leadership of Black communities and folks doing work within Black communities. So that it is not work being done on behalf of, but it is work being done by Black communities and Black leaders and Black healthcare workers and policymakers inside this health space. And I think, yes. And as I said, in terms of the long-term piece around race-based data collection and accountability being one of the important pieces, is that what we must have strategies embedded in our healthcare system, that the initiatives that we move forward now, that the healthcare systems and other parts of the system are held accountable for delivery on a Black health agenda and on Black health plan initiatives, so that again, we're not in that place where it becomes a for the moment event. We're after the spotlight on anti-Black racism wane, then so too will the spotlight on moving forward with meaningful strategies to improve Black life wane. So hence they need to be embedded in some of the accountability levers that we have. So I will end there and have my sister Cheryl continue the conversation.
Wonderful. Thank you so much, Angela, for again teaching me as well, and thank you for the opportunity to speak to many of you in the audience who I believe have been comrades in this struggle and partners in the work that we do here in Northwest Toronto. As the Executive Director of Black Creek Community Health Centre, we've been doing this work for a long time, and it's been a privilege to work with many, including those on this panel. And in my portion of the presentation, I'll be sharing how our engagement strategies with the Black community here in Northwest Toronto adheres to the various pillars that Angela just spoke about. But before we get started, we have another poll question for you. And the question is your public health or healthcare organization engaging with Black communities in a manner that respects self-determination? So we'll give you a few minutes to enter your answers. Okay, so we have it now. So great, happy to see that 36% of you answered yes to that question, 19% no, 37% don't know, which is fair, and 8% not applicable. And I think that answer of not applicable is something that we do also that informs this conversation as well. So let's get started by I'd like to get started by saying that it's very clear to us at the front lines that a commitment to improving the experiences of the Black community members really requires developing engagement practices and methods that reflect our Black communities. We understand that listening and respecting the voices of the community are key components in building trust and fostering self-determination within groups of people that have been historically oppressed. And over in this slide, basically just shows some research that was conducted by the African Canadian Civic Engagement Council and the Innovative Research Group. And again, showing us nothing that many of us do not know, that Black Canadians fared much worse than white Canadians, both in health impacts and in economic hardships due to COVID. In fact, many of us believe that these results only showed what we've known for some time. And these poorer health outcomes for Black people were just exacerbated and illuminated by the pandemic. Data from other parts of the world showed the high morbidity and mortality rates of Black people due to COVID-19. And we know that much more robust data is needed here in Canada to fully understand how COVID-19 has disproportionately impacted the lives of all Black Canadians. In the next slide, just wanted to highlight that the studies from the UK and US showed a strong association between high coronavirus rates and low-income conditions of work, visible minority status, and low levels of education. And marginalized populations had disproportionately high morbidity from COVID-19. Their survival rates were lower in under-resourced and low-income neighborhoods than in more affluent neighborhoods. And interestingly, this slide just shows a picture of the Northwest Toronto neighborhood. And these conditions are found in many similar neighborhoods in Ontario. we are often described, these neighborhoods are often described as an urban inner city area. And this community in Northwest Toronto in particular was grappling with escalating gun violence during the course of the pandemic as well. In the early stages of the pandemic, in the next slide, a news report from Global News painted a grim picture showing the strong association between neighborhoods in Toronto with a high number of coronavirus cases and those with a higher population of Black people. And this only further supports the health inequities that impact these communities, specifically due to anti-Black racism. And this is according to many experts. According to the 2016 census, the percentage of Black residents in several Northwest Toronto neighborhoods was in the range of 25 to 30%, compared to 9% for the city of Toronto. So, and in the next slide, another report, again, exposed the fact that despite the high rates of infection in these neighborhoods, the COVID response was less than robust and did not take into consideration some of the characteristics that I just described of these neighborhoods. For example, testing and assessment centers that required appointment bookings or required travel to sites far from the homes. And these were not conducive to people without access to devices or internet or money for transportation. So one of our first actions was to advocate for low barrier testing sites for the population groups in these neighborhoods that were walk-in, closer to populous areas such as buildings, the lobby of buildings. We also had to engage swiftly with community, especially to combat some of the conspiracy theories that were there very early and brought back reminders of a long legacy of racism that has fueled the mistrust and distrust in our medical system. And I'm sure you all recall the renewed conversations about the Tuskegee experiments in the 30s that impacted Black people and Black lives. In the next slide, this just describes our engagement strategy that really centered on the people we wanted to engage in our COVID response. We made them, the people, our compass that led us to the required solutions. We knew that people in these communities had precarious jobs without the flexibility to book appointments at assessment sites or vaccination sites. We designed a walk-in model, again, as I mentioned earlier. We recruited community ambassadors to outreach and help people understand safety issues around COVID, the importance of testing. They were involved in distributing PPE, and most importantly, they were crucial. And they were crucial in building trust across the different population groups that we served. Further, as you'll see in the next slide, it was really important for us when thinking of the Black population that this is not a homogeneous community. It is heterogeneous, comprising of subpopulations, and each of these subpopulations have their own unique characteristics and health profiles. Of the over 250,000 Black people in Toronto, we have a plethora of origins that include those who were born in Canada, in the US, the Caribbean, Latin America, and the African continent. Each group with common but unique histories and experiences that form their identities, which also include the intersection of gender, sexual orientation, family and economic status, and so much more. Black people must be recognized as an essential subpopulation when utilizing population health approaches. And to do this, you need hyper-local approaches to engage each of these subpopulations within our communities. And in the next slide, we understood that we needed to avoid the pitfalls that many of us have seen with the one-size-fits-all approach to broad population health. But we had to offer unique opportunities and build on community strengths and assets, which is where we started. We, again, by employing community champions, leaders, influencers. These individuals are later termed community ambassadors, but they guide us. They were we use them as our compass to guide us to the strategies and to engagement with our community members. And when vaccines were finally approved and the vaccine supply was allocated equitably to our community, we utilized the same approaches we did for testing, with community ambassadors leading the way. In the next slide, we also ensured that the staffing was representative of the subpopulations within the community. And we did this through partnerships with organizations, with grassroots organizations, with Black physicians, and targeted recruiting to reflect the community. Again, this slide simply shows the diverse partnerships we worked with, and the fact that we reached folks where they were at. We use diverse spaces, and that's fine. You can go to the next slide. Diverse spaces such as churches, shopping malls, basketball courts, community centers, apartment buildings. We went where people were at and were most comfortable. And along the way, in the next slide, through our diverse partnerships with community ambassadors and other staff and partners, we also adapted our communication material that reflected our target audience in the most respectful way, with a message of caring, and caring that people deserve, people, including Black people. In the next slide, this simply showed that the numbers reflected our successes. When we started our vaccination efforts in April of this year, some of the neighborhoods in the Northwest area were at 5% vaccination rates compared to 25% in other parts of Toronto. Now, 6 months later, after working with the variety of partners and engaging with leaders such as Angela, who really helped to ensure that these communities had an equitable supply of vaccines, we were able to vaccinate over 50,000 people in the community. And while our target population was a Black community, and we did collect sociodemographic data, including race-based data, we do not have access to this data to really demonstrate our success in reaching our target population. However, it is a success to know that within all the efforts in the community, most of the neighborhoods in Northwest Toronto are now at or near the provincial average of about 80% in these neighborhoods. And the next slide, I think simply again shows some of the neighborhoods with the highest population of Black individuals are still falling a bit behind in unvaccinated individuals. However, we are going there. And in the next slide, moving forward, beyond our vaccination efforts, such as promoting booster shots for eligible groups and readying our teams for children's vaccination, we'll be turning our attention to address some troubling health concerns within the Black community that were only exacerbated during the pandemic. We recognize that over the past 2 years, the health system has changed, at least transiently, and it's shifted to caring for patients with COVID-19 and preventing the transmission of the virus. So people with chronic diseases such as diabetes, high blood pressure, sickle cell anemia, many of those that with higher rates in the Black community have had precarious and interactions with their healthcare providers. We must pay some attention to this, along with dealing with long COVID, which has affected, as we know, the numbers of Black individuals with COVID will have to deal with long COVID, and we have to ensure that they are supported in an equitable manner in the same way that we are now doing our distribution of vaccines. We have to remember that these illnesses are there. We have concerns about virtual care options and the lack of digital equity in the Black community, and we must be ready to equip these individuals and their caregivers with the resources to manage their conditions at home with the support of their community. The next slide, I believe, again, just shows that we will be incorporating many other health promotion and education activities within our vaccine clinics moving forward. And while in the next slide, while we're very happy to see the numbers that we've achieved in getting shots into arms, there's nothing more gratifying than the personal feedback from those we serve. I just wanted to read the social media post of someone who received a vaccination at one of the clinics with their partners at the Jamaican Canadian Association and with the Black Physicians of Ontario, saying that she's incredibly grateful for the work of the Black health professionals for organizing a pop-up for us and by us. To see so many Black vaccinators in the same room and a DJ for good vibes was just incredible. As someone who is chronically ill and has chronic pain and disabilities, the medical system has been a shitty place, to say the least. But yesterday made me hopeful for communities of care and alternative healthcare practices that are human-centered and actively combat medical racism. A giant thank you to all. And in my last slide, I'd just like to end with this quote that was from over 100 years ago by W.E.B. Du Bois, which said, "The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation towards the well-being of the race. There have been few other cases in the history of civilized people where human suffering has been viewed with such peculiar indifference." I'd like to end by saying that I hope we don't have to wait another 100 years to really work towards improving the lives of Black people. As a favorite poet of mine, Audre Lorde, wrote, "The master's tools will never dismantle the master's house." We've had numerous recommendations made by Black leaders. We have a Black health plan. The roadmap is within these pillars, as stated earlier in Angela's presentation, to improve Black health by changing structural and systemic sites of inequality. Again, let's not wait 100 years to do this. Thank you.
Thank you. So I think that is the key. It's thinking about how we can do this differently and better now. And Angela has brought kind of the provincial lenses to how that can happen. And Cheryl has brought the lens from the front lines. And so for me, actually, the title of this session being Public Health 2.0 actually came from those sessions that Cheryl just described a patient's feedback from, where we were at the Jamaican Canadian Association, and a person who'd come for vaccination said, "This is public health. This is next level public health." And the person didn't know that I was a public health physician, but I really thought about that because it's where we are able to bring in voices that have not been previously at the table, where for us as Black physicians, we've learned so much from our Indigenous colleagues about creating a culturally safe environment. We have incorporated concepts of the South African principle of Ubuntu, I am because we are, and that came out in the quote that Cheryl said of human-centered. And we've done this in collaboration with public health units as well. So my section is going to be very brief because we only have so much time. So I'm going to skip the last poll, actually, and I'm just going to give an example of what that looks like in action and a bit about the BPAO. So I'm going to skip this poll and to say, so for the Black Physicians Association of Ontario, we entered this work, although it is not really our core work. We're a volunteer organization with a mandate to focus on increasing the number of Black physicians in the province and advocating around issues of health equity and engaging in that type of research. But with the pandemic, as we saw the unique situation where we were and have been more vulnerable in our communities due to anti-Black racism and the distrust for the vaccine, we've partnered with a number of different Black community organizations. And we created the Black Health Vaccine Initiative, which has 3 pillars: to advocate, educate, and vaccinate. And the advocacy is around letting institutions know the legacy of anti-Black racism and how that plays out today and how that needs to change. supporting the prioritization of Black communities as it's been advocated for by Black communities, providing culturally safe, appropriate education on vaccines, and providing culturally safe spaces for vaccination to occur. And so we've worked with a number of partners, and that's why I say I feel like this is Public Health 2.0, where we were largely, not always, but largely able to be focused on a Black-led, Black community-led lens, and other partners joined in solidarity. And so it has been a wonderful journey in the context where it has worked well. Over the summer, we administered over 40,000 doses to high priority areas, which were Black predominant areas, but we also administered vaccines to many BIPOC communities and differently abled communities, different communities that felt safe in our settings, and so chose to come to us to be vaccinated. And so, you know, I can show you graphs, I can show you things, but I thought I would show 2 quick 40-second videos before we have to adjourn that kind of capture the moment. So I'm actually going to stop the share and show the videos, the 2 videos very, very quickly. And so 2 very quick videos, one of testimony from a member of community and another one with a provider.
I wasn't so much into getting the vaccine, but because of the health history of my family and my mother being in remission from breast cancer and having a compromised immune system, I felt it was necessary for myself to be fully vaccinated. So I encourage everyone to come out and get vaccinated, not only for yourself, but for your family and others, especially if you're traveling. You want to protect yourself and be safe and healthy.
Because this is who we are. This is for us, for our children, for our children's children, and we know the barriers that we all have in accessing care in general. The pandemic itself has just highlighted the barriers that the Black community faces. So I'm just hoping that this is just the beginning of collaborations amongst all of us that will improve the health and well-being of all of our people, in particular the Black community.
Okay, so I felt that showing that, you know, we can tell you about it, but that's the way that we can show you what Public Health 2.0 looked like in our context. And so I'm just going to now provide some concluding slides, and then we will go to Q&A. And so just to say, for the bpao for 2022, in partnership with our communities, and of course, shout outs and big up to all the physicians and everybody who works with the Black Physicians Association of Ontario, all of our partners, public health partners, healthcare partners, but in particular our community partners with their innovation and everything that we have been able to do. And so the 4th pillar is going to be looking much more broad beyond vaccination. And so it's, yes, we advocate, yes, we educate, yes, we vaccinate, but we're going to be doing rejuvenate and looking at prevention and wellness and social determinants of health. And with that, we will also evaluate. And so that is coming. And so we are looking forward to doing more of that with our partners. But this is just a small piece of the broader Black Health Plan that was presented to you today. So I want you to kind of think of that case example, but it is not limited to that, as to how public health can be done in a way that respects Black self-determination and our commitment towards health equity. So in conclusion, I'm hoping that through this, we were able to give you a sense of the plan for the Black Health Plan, the need for collection and sharing of race-based data, because it hasn't always been shared with our communities who have agreed for their information to be collected. So the sharing of that race-based data, the long-term impacts of COVID-19, and how public health units and other healthcare organizations should partner with Black communities. And so we thank you, and shortly after this, I guess I will ask Dr. Carl to come and take on the Q&A. I did receive a text about my statement about 3 generations since the abolishment of slavery, and I want to clarify that I didn't did not mean the Western technical definition. I meant more of the African collective community definition, in the sense that we do have elders who remember a great grandparent or grandparent who had been born under the slavery regime. And so that is what I was referring to. It is still in our collective memory. Thank you.
Thank you very much. Thank you, Ani, Angela, and Cheryl. And now we'll move into the Q&A pod to address some of your questions. So please continue to enter your questions into the pod, even as we're talking. And if you've not had an opportunity to do so, now is a good time. We're actually going to extend the time of this session by 10 minutes. So we're going to end at 1:10 instead of 1 o'clock, just to make sure everybody gets a chance to ask their questions and for us to have a full discussion. So we have a lot of questions. I'm going to jump right in. First question is from Raz X, and he says, how will you all address with your partners Black indigenous cultures? For example, the refusal of indigenous African communities rejecting the vaccine mandates globally. So kind of taking the same concepts and applying them in a global sense. And I know that might be beyond the scope of your work individually, but does anyone want to comment on that?
Well, I'll start by saying that when we speak in a lens of intersectionality. So particularly, you know, I'm embryonic in my journey in Black feminism, to be honest, but my co-leads are much more familiar. But it really does mean, when we talk about Black communities, you can be Black and indigenous, you can be Black and Jewish, you can be Black and differently abled. So that is our center point. And specifically for our work, we have been engaging, like I said, in solidarity with indigenous communities, and also, you know, had a vaccine clinic in solidarity on the day of National Truth and Reconciliation. So we already do that work, and at its root, I think for many of our communities, it's still that experience of systemic racism and the legacy of colonialism. So many of the approaches to address that and respect the intergenerational wisdom that has caused some people to pause when it comes to the vaccine. We respect that, listen, and have those conversations. I don't know if Sister Angela or Sister Cheryl have something else to add to that piece.
Just quickly, the one thing I would add is, so in terms of the question around the rootedness that Black populations geographically as well, we also have our place of our indigenous origins, and that in those spaces that hesitancy does exist because of historic and contemporary injustices that brings about mistrust. And therefore, we need to, I believe, we need to enable time for education, but we also need to have our community members, Cheryl's team, Ani's team, and others be in front of the education for our communities, because it, you know, Cheryl identified Audre Lorde's quote, the master's tools and the master's house, is that we need to be in front of our communities to speak to and affirm the contemporary and historical events that has given rise to mistrust, and provide time to talk that through. And then in that time as well is to enable what are the risk mitigation strategies that we still need to put in place for our community members who have not been or have not chosen to be immunized because of those mistrusts. And I think sometimes what has happened, and this is for me about racism as well, and the pernicious nature of it, is because community members have chosen not to be immunized because of mistrust, is then they're dismissed and then just left at risk. And I think that they remain, those community members remain, I think, our community members whose lives remain important, and our supports need to still surround and circle them. Thank you.
Okay, Angela, we have another question for you, actually. Sister Outsider says, thank you, Dr. Robertson, for your amazing presentation. I'm wondering about data sovereignty, and if you suggest Black communities put something in place similar to many First Nations to maintain some control of the gathering, ownership, and application of the data that is collected on Black populations.
So I think definitely, and it may not look exactly like the framework that Indigenous communities have pulled together, which has a governor to governor, government to government relationship around data governance. But I think what we have articulated in the EGAP, which is the Engagement, Governance, Access, and Protection Framework, and there is a link to that paper that when the document gets sent out, is that there must be, when data is collected, so for example, in your public health unit, for example, where data is collected, is simultaneously, it would be valuable for a structure and processes to be pulled together that have expertise around analyzing that data from the community, expertise from the community, be part of the analysis, that the community is engaged about how that data gets released and the recommendations coming out of that, that data collection, and that there is some accountability process about how that data is governed and how that data is enabled to be accessed by communities outside of your unit, for example. So I'm not suggesting that we have one advisory that govern Black people's data. I'm more so recommending, and I think the EGAP framework is recommending, that we develop local strategies that are accountability strategies that match and fit the populations and communities. Because as Cheryl identified, Black communities is not a monolith, and therefore we cannot have a one size fit all, but we can certainly have a framework that can be adapted for all.
Okay, we have a lot of questions. This is great. A lot of great participation. Let's move right to the next one. This question is, a collection of race-based data is so important and yet so challenging. People, staff in health organizations, don't want to ask, and respondents sometimes don't want to tell. So the question goes on to talk about how, with limited resources, limited time, when you're talking to people in the community, you're trying to move quickly. But can you talk about how to overcome some of these challenges of that don't ask, don't tell, and this idea, or frankly, myth that, you know, this should be a colorblind society and we shouldn't even be asking? How would you respond? Let me throw I'll throw it to Cheryl.
Okay, so this is something that we heard about a lot as we did this work, but community health centers, especially those in Toronto, have been leading this work for a long time. We ask because we care. That's our message to those that we interact with. In the community vaccine clinics that we did, we collected race-based data throughout at all of our clinics. Unfortunately, the data set is too small for us to make sense of it, and it's unfortunate because one of the excuses was it's too difficult, the staff are uncomfortable. Well, this is not a comfortable place to be. The communities we work with are not comfortable, and I think we have to work with each other to build our comfort and put the resources. The system has to put the resources into ensuring that we have the proper training, education, and understanding of these inequities that have brought us to this place, that because without the data, we are really flying without that compass, to guide us and to know where we're going. We need the information. We need the information, and we need to ensure that our communities understand that they trust us with the information. Further to data governance and sovereignty, people need to know that we're collecting their information for them to know it and be very transparent about it.
Yeah, sorry, can I also just add? So I agree with Cheryl, but also I think there's just a discomfort with race. And we live in a society where there is everyday racism that is killing people. We in public health and in healthcare know how to ask people about their sexual health, and sometimes, honestly, chase chlamydia around a tree, trying to get information. So I think we are very well equipped in being able to learn and get the training to be able to collect race-based data. There just has to be the will to kind of move that forward. And we found creative ways during the pandemic to collect it.
Thank you, Ani. Julian asks, I'm excited to hear you use the term comrade. I believe that was you, Angela, who used the term comrade, a term rooted in socialist movements. Can you speak to the role you see public health playing in broader political movements?
So Julian, I'm notorious for pushing some of the boundaries, and I feel that the work that we're doing and this conversation is really rooted in social change work. So we're not just having this conversation just because we're having this conversation because we want to make changes that will address sites of systemic inequality. And therefore, I believe that it is a social justice effort, and hence my use of the term comrade in its most positive and best sense. I think that the role of in terms of public health in that effort is public health are and have historically been kind of the canary in the mine, citing here are the sites of deprivation, here are the sites of inequality, here are the sites of risk and gaps that will create harm for some and all. And by virtue of being that space and having that responsibility, is the work is not just to say, hey, this is happening here. The other piece of the work is this is happening here and this is what we need to do. So public health units, I believe, must also be about action-oriented to address and ameliorate the sites of inequality and the sites of injustices and the sites of deprivation and poor health outcome, not just the criers, the town criers about the crisis. And it is, and because the issues that surface are not just issues that are within the sphere of health, they're within the broad social determinants of health, is therefore public health unit voice must be a voice that cascades across the determinants of health framework, because those are the things that give rise and contributes to the deepening inequality. So definitely I agree with you, Julian, that there is a role. And I think that the role is both an alert and an action plan.
Okay, next question. How engaged is your work in Northern Ontario? We often find ourselves struggling to bring to bear the importance of the work you are doing to parts of the province that are not seen as having significant Black communities, but then the questioner says, we do exist here. Any findings you can share around Northern Ontario, Black communities, and the pandemic?
So I will have to say that I don't have specific data. We do know that for Black communities, because anti-Black racism is an ecological phenomenon, you find it everywhere, that we know in the UK and the US and in Canada, Black communities have had distrust with regards to the vaccine. So I would presume that in Northern Ontario, it is no different. But Northern communities for BPAO and many of our partners have been on our minds because we have less access to Black physicians out there and nurses who can provide that culturally safe care. So the BPAO is working with Scarborough Health Network's VaxFax phone line to, which is available provincially even right now, but to have it to have access to Black physicians who can provide one-on-one information. So we should have that by next month in place. So please do check the Black Health Alliance website where we'll have more information on that. But we do want there to be more equitable access to that kind of Ubuntu-centered, culturally appropriate vaccine education and care.
And
Cheryl.
may I add that also, as Angela and I both belong to the Alliance for Healthier Communities, and we do have partners and sister community health centers, Aboriginal access centers, and other team-based care organizations in the North. And we're happy to share this work with our colleagues, because we do know that in isolated communities, it could be even worse. The impact of the violence of racism could be even worse for some of our sisters and brothers. So we do know that every life matters when it comes to what happens with Black people across our country.
Okay. Next question. Thanks for organizing this worthwhile session. My question: to what extent are agencies such as Public Health Ontario committed to using data on the impact of COVID-19 on Black communities in policies relating to recovery and other relevant strategies? Okay, so maybe I'll start by saying from a Public Health Ontario perspective, first of all, just to be clear, PHO doesn't set policy. Our role is to gather data and information and help to interpret it so that decision makers can make the policy per se. What I can say is that PHO is committing itself to looking at race-based data, being a more effective partner in community. We're currently working on some of that, those initiatives now, and we'll have more to say about that in the future. But let me take this opportunity to pass it to our panel and let you critique, and you tell us how are government agencies doing, and how is the government and local public health and so on in your view. And we're getting a little short on time, but please, I want to give you this opportunity. Any takers?
So I'll be so bold.
Okay.
I'll be so bold to say that there has been inconsistency across public health units around taking up the development of not just of Black health oriented strategies, or strategies for Black populations around health improvement, but also in terms of the collection and the utilization of race and race twinned with sociodemographic data to inform the plan. So for me, and I see a later comment from Dr. Lamptey in the chat, is one of the pieces for me would be wanting to see a consistent direction across public health units to collect and use race-based data, race and socio-demographic data to advance not just the surfacing of inequality, but the building of strategies for change, for change and action. So that would be one comment I would offer.
Okay. Very good. Unfortunately, now we are out of time. Thank you, everybody, for the participation. I wish we could have gotten to more questions. But as we wrap up today's PHO round session, I would like to thank Ronnie, Angela, and Cheryl for presenting. And I would also like to thank everyone who joined us for today's session. It's great to see such strong virtual participation during such a challenging time for healthcare professionals and for all of us, really. You can expect to receive the brief and anonymous PHO rounds survey for today's session. Please try to complete this to help us to improve our programming. And lastly, to access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website. Head to education and events on the website and click on presentations. And you'll also be able to see this presentation as well, in case you wanted to review it or share it with people you know. So thanks to everybody, thanks to the panel, and have a wonderful day.